Remove this medicine from your home now. It silently harms your bones." She seemed fine. She walked daily. She cooked for her grandchildren. She never smoked. One small trip in the kitchen, a fall no one expected, and the hip that should have taken decades to fail shattered the life she knew. When the doctors looked closer, the fracture told a story of bone that had been quietly losing strength for years. Silent, invisible, and easily missed. Before you reach for a pill bottle and panic, do not stop prescribed medications on your own. Many of the drugs I'm about to describe are treating serious conditions: cancer, seizures, autoimmune disease, hypothyroidism, severe reflux. The goal here is not to terrify. It's to inform, to give you the words to bring to your clinician, to audit what's in your home and make a plan together so your bones don't pay the price. Let me explain why this matters. How 5 common medication classes can weaken bone in different ways, and exactly what to do next. Step by step, the precise test to ask for, and the exact phrases to use with your doctor. Bone is living tissue. It isn't static. Think of bone like a constantly remodeled house. On one team you have the builders, osteoblasts, laying down new bone and patching damage. On the other team you have the demolition crew, osteoclasts, breaking down old bone so remodeling can happen. Health depends on balance. When that balance tips toward demolition, bone becomes thinner, more fragile, and easier to break. The frightening part, this can happen quietly. You won't feel it, no pain, no warning, until a small fall turns into a major fracture. Now I want you to do something practical. Go to your medicine cabinet right now. Grab every prescription bottle, every over-the-counter box, even supplements. Look at the active ingredient on the label, the small line that says the drug name, not just the brand. If you can't get up right now, remember to do it in the next 5 minutes. I'll wait. If this alert is making sense so far, please like and subscribe. I'll follow this video with a detailed guide on how to rebuild bone safely after we finish this medication audit. If you've got your medicines in front of you, great. If not, write this down and check as soon as you can. We're going to count down 5 classes of drugs that commonly, and sometimes quietly, harm bone. For each one, I'll tell you the active ingredients and common brand names, who usually takes them, how they damage bone, what signs to watch for, and exactly what to ask your clinician. Number 5. Aromatase inhibitors. Examples: anastrozole, arimidex, letrozole, femara, exemestane, aromacin. Who takes these? Postmenopausal women with hormone receptor-positive breast cancer, often for years after surgery or chemo. How they harm bone. Aromatase inhibitors lower estrogen. Estrogen is one of the most important protectors of bone in women. When estrogen drops, the demolition crew, osteoclasts, gets more active. Bone resorption accelerates. The result: faster bone loss and increased fracture risk, sometimes within a year of starting therapy. What to watch for. Back pain that might suggest a vertebral fracture, loss of height over time, or nothing at all until a sudden fracture. What to ask your oncologist. Can we check a baseline DEXA scan and repeat it periodically while I'm on this drug? If my bone density is low, what bone-protecting options do you recommend? Also ask, if I need to stay on this medicine, what preventive measures will you put in place? Why this matters. For women taking these agents, bone protection is a parallel priority to cancer therapy. In many cases, oncologists will recommend bone density monitoring and may start a bone-specific medication if risk warrants it. Don't stop your cancer medicine. Bring the problem to your oncologist and ask for a plan. Number 4. Enzyme-inducing anticonvulsants. Examples: phenytoin, dilantine, carbamazepine, tegretol, phenobarbital, Gardinol. Who takes these? People with epilepsy, but also patients treated long-term for neuropathic pain, trigeminal neuralgia, or some mood disorders. How they harm bone. These drugs ramp up liver enzymes, what we call cytochrome P450 activity. That speeds clearance of vitamin D. Less vitamin D means lower calcium absorption from the gut and less of the active form your bones need. Over time, this leads to weaker bone. What to watch for. Fatigue, muscle weakness from low vitamin D, or again, no symptoms until a fracture occurs. What to ask your prescriber. Can we measure my 25-hydroxy vitamin D level and consider supplementation if it's low? Should we check calcium levels and do periodic bone density testing? Use these words if it helps. Doctor, could this medication be lowering my vitamin D and affecting my bones? Why this matters. Some anticonvulsants are essential and can't be stopped without risk. The fix often isn't stopping the drug. It's monitoring vitamin D and calcium and replacing what's depleted under medical supervision. Number 3. Excess thyroid hormone. Over-replacement with levothyroxine. Examples: levothyroxine, Synthroid, Levoxil, Euthyrox. Who takes this? Patients with hypothyroidism or after thyroid surgery. Levothyroxine is very common, especially in older women. How it harms bone. Too much thyroid hormone increases overall metabolic rate, including bone turnover. That means both building and demolition rates accelerate, but demolition outpaces building and net bone is lost. Over time, over-replacement increases fracture risk. What to watch for? Symptoms of excess thyroid, palpitations, weight loss, tremor, are clues. But older patients often have few symptoms despite aggressive doses. The silent danger is bone. What to ask your clinician? Could my levothyroxine dose be too high for my age? Can we check my TSH and adjust the dose if needed? If my TSH is suppressed, should we check a DEXA scan? Why this matters? Thyroid dosing needs periodic reassessment, especially as people age. Many women have been on the same dose for years without rechecks. Ask for TSH testing and a conversation about whether your dose is still appropriate for your current health and bone goals. Number 2. Systemic glucocorticoids. Examples: prednisone, deltasone, prednisolone, dexamethasone, decadron, methylprednisolone. Who takes these? People with autoimmune disease, severe asthma, inflammatory lung disease, some cancers, sometimes as short courses, sometimes as chronic therapy. How they harm bone. Glucocorticoids attack bone on multiple fronts. They directly inhibit osteoblasts, the builders, so new bone formation drops. They increase osteoclast activity, the demolition, so bone is broken down faster. They also reduce calcium absorption from the gut and increase urinary calcium loss. The combination is potent. Significant bone loss can happen within months of starting high-dose therapy, and even lower doses over long periods increase risk. What to watch for? New or worsening back pain, loss of height, or fractures that occur after minor trauma. What to ask your prescriber? Can we minimize steroid dose or use alternate therapies? If I need to be on steroids, what bone-protecting measures will we start? Should we check a DEXA now and repeat it at intervals? Why this matters? When steroids are unavoidable, active prevention matters. Baseline bone density, calcium and vitamin D optimization, and sometimes bone-specific medications to prevent rapid loss. Discuss dose minimization and steroid-sparing options with your specialist. And now, number 1, the most common, the most overlooked, the one sitting in many medicine cabinets sold over the counter: proton pump inhibitors, or PPIs. Examples: omeprazole, Prilosec, esomeprazole, Nexium, pantoprazole, Protonix, lansoprazole, Prevacid. Who takes these? Millions of people with heartburn, GERD, reflux-related esophagitis, or who use PPIs for stress ulcer prophylaxis. Many use them long-term, sometimes without re-evaluation. How they harm bone. PPIs reduce stomach acid. That sounds harmless for reflux, but acid is important for absorbing certain minerals: calcium, especially calcium carbonate, magnesium, and iron. If less calcium and magnesium are absorbed, bones lose essential building blocks. Some studies, mostly observational, link long-term PPI use to higher fracture risk. Emerging mechanistic work, including animal studies, suggests PPIs may also affect bone cells and mineralization pathways, but human causation is complex and still being studied. What to watch for? There are often no symptoms until a fracture. Watch for chronic nausea, bloating, or if you've been on a PPI for years without a recent reassessment. What to ask your clinician? Do I still need this PPI long-term? Can we try stepping down or switching therapies? If I need to stay on it, how will we monitor my bone health and mineral levels? You can add: can we check my magnesium, iron, 25-OH vitamin D, and consider a DEXA if I have other risk factors? Why this matters? PPIs are widely available and easy to continue without oversight because they cause 3 simultaneous threats: reduced calcium, magnesium, and iron absorption. They're especially stealthy. If you're over 50, or you combine a PPI with steroids or another drug that impairs bone, the risks add up. A quick reality check. If you find none of these medicines in your cabinet, good. This is less urgent for you. If you find one, it's time for a conversation. If you find two or more, pay extra attention. Risks don't just add, they multiply. For example, a woman on aromatase inhibitors who is also taking a PPI and a low-dose steroid faces a much greater combined threat to bone than any single medication alone. How to score yourself. Count how many of the 5 classes appear on your list. 2 or more. Schedule a discussion with your prescribing clinician soon. 1. Still worth asking the right questions. Now that you know the classes, here is a practical, clinician-friendly, 4-step bone protection protocol you can use right away. Step 1. Audit. Make a clear list. Include every prescription, every over-the-counter medicine, every vitamin and herbal product. For each entry, write the active ingredient, the dose, and who prescribed it. Include frequency and how long you've been taking it. Having this list makes your appointment efficient and actionable. Step 2. Ask. Bring that list to your next visit and use short, direct phrases. Here are lines you can read aloud. Doctor, could this medication affect my bones? Can we check a DEXA scan and these blood tests? Serum calcium, magnesium, 25-hydroxyvitamin D, ferritin, iron studies, and TSH. Is my levothyroxine dose still appropriate for my age and symptoms? If I need to stay on this medicine, what can we do to protect my bones? Can we reassess the need for long-term PPI use or try stepping down? These phrases work because they are specific and clinical. They signal to your clinician that you want actionable monitoring and a plan. Step 3. Tests. Ask for the right tests. Don't accept vague statements like, "We'll watch you." Request concrete data. DEXA, Dual Energy X-ray Absorptiometry. The standard bone density test. Understand results. A T-score of 1.0 to 2.5 is osteopenia. ROSE, 2.5 meets the usual definition of osteoporosis. DEXA gives you a baseline and a way to track change over time. Serum, 25-hydroxyvitamin D. Tells you if your vitamin D status is low. Serum calcium and magnesium. Low or abnormal levels can point to absorption problems or other issues. Ferritin and iron studies. Iron deficiency can be a clue to malabsorption or chronic blood loss and is relevant when PPIs are in play. TSH. To check whether levothyroxine dosing is appropriate. Depending on your history, your clinician may also check markers of bone turnover or kidney function before starting bone-specific medications. Step 4. Replace and support. If tests show deficiency or bone loss, talk about options, always in partnership with your clinician. Replenish deficits. If vitamin D is low, your clinician will recommend an individualized plan to correct it. If calcium intake is inadequate and you have low levels, discuss dietary changes and possible supplementation. Address mineral deficits. If magnesium or iron is low, discuss replacement and investigate causes, which may include chronic PPI use. Medication strategies. If the risk is high enough, bone-specific drugs, anti-resorptives like bisphosphonates or denosumab, or anabolic agents in certain cases, may be appropriate. This is a clinical decision based on DEXA, fracture history, and overall risk factors. Lifestyle. Weight-bearing exercise, smoking cessation, limiting excess alcohol, and fall prevention all matter. But lifestyle alone won't fully reverse medication-induced losses in many patients. It's part of a combined plan. Here are a few real-world examples of how this protocol works. Case. A woman in her early 60s comes in on anastrozole after breast cancer treatment. She had never had a DEXA. We ordered a baseline DEXA and vitamin D level. Her DEXA showed low bone density. Vitamin D was borderline low. Together, we started vitamin D replacement and discussed starting a bone-specific medication to reduce fracture risk while continuing effective cancer therapy. The oncologist and I coordinated care. Outcome: she kept her cancer therapy and lowered her fracture risk by adding bone protective measures. Case. A man in his 70s had taken a PPI for heartburn for many years without reassessment. After a small wrist fracture, he had a DEXA and labs. He had low magnesium and low vitamin D. We discussed stepping down the PPI and trying alternative treatments for reflux, while correcting mineral deficiencies. His fracture risk decreased after combined measures. A few important clinical notes as we think about tests and interpretation. DEXA gives a T-score and sometimes a 10-year fracture risk estimate. Use both numbers. One tells you bone density, the other gives context for overall fracture probability. Lab values must be interpreted in context. For example, a normal serum calcium does not rule out poor bone health. Vitamin D and magnesium are often more telling when medication-induced absorption problems are suspected. If you are on anticoagulation or have kidney disease, the choice of bone-specific therapy may differ. That's why specialist input, endocrinology, or bone health clinics can be helpful. Let me shift for a moment back to the human cost. When bone loses strength, it's not just a single fracture. A hip fracture in an older adult often triggers a cascade. Months in the hospital, surgery, prolonged rehab, reduced mobility, loss of independence, and higher risk of complications including infection, blood clots, and even cognitive decline. Studies show that many older adults who suffer hip fractures never regain their prior level of function, and mortality in the year after a hip fracture is significantly increased. These are real consequences, affecting families, caregivers, and quality of life. I want to tell you one more compact story. Call it the spark story. An active man in his late 70s, I'll call Mr. Hayes, had a minor fall and a wrist fracture. He pushed through. Months later, he fractured a vertebra. He lost confidence and stopped walking daily. Within a year, he had lost muscle mass and was more socially isolated. His doctor later discovered he'd been on long-term prednisone for a lung condition and a nightly PPI. Vitamin D was low, and DEXA showed osteoporosis. The physical fractures were only the tip of the iceberg. The spark of one small break lit a slow decline. That's why we act early. Before we close, a few practical, precise scripts you can use when you make the call or sit down with your clinician. You can use these verbatim. Doctor, could this medication affect my bones? Can we check a DEXA scan and these blood tests? Serum calcium, magnesium, 25-OH vitamin D, ferritin iron studies, and TSH. Is my levothyroxine dose still appropriate for my age and symptoms? If I need to stay on this medication, what bone-protecting options will you recommend? If your clinician says the medication is necessary, which sometimes it will be, ask directly, if I need to stay on this medicine, what can we do to protect my bones? That question shifts the conversation from blame to partnership and opens the door to monitoring, supplementation, and referral to a bone specialist if needed. A few caution points to keep this practical. Do not stop medications without a clinician's approval. Stopping an anti-seizure drug or a cancer therapy without supervision can be dangerous. Not every person on a PPI or steroid will suffer fractures. Risk depends on dose, duration, age, baseline bone density, and other risk factors. But identification and monitoring is the prudent path. When I reference studies, I am careful. Observational research links some of these drugs to higher fracture risk. Animal research has suggested mechanisms. That is why we use clinical tests and individualized decision-making. If you want a quick checklist to bring to your appointment, here's what to include on a one-page printout. List of all medications with active ingredients and durations. Recent symptoms, falls, new bone pain, loss of height. Questions, the exact scripts above. Tests requested, DEXA, 25-OH vitamin D, serum calcium, magnesium, ferritin, iron, TSH. Space for clinician notes and next steps. One more important concept, the additive risk. If you are on 2 or more of these medication classes, your risk is not simply doubled, it can be synergistic. A PPI that reduces calcium absorption combined with prednisone that increases bone loss, or an aromatase inhibitor plus low vitamin D from enzyme-inducing anticonvulsants creates a much more hazardous environment for bone. That is exactly when a careful, proactive plan is most critical. What you should do right after watching this. 1. Audit your medicine cabinet. List active ingredients and durations. 2. Bring that list to your next appointment. Use the scripts I gave you. 3. Request the tests I named if you have one or more of the risk medications. 4. If your results show deficiency or low bone density, discuss replacement and bone-sparing options with your clinician or a bone health specialist. Share this video with a family group whose members take daily medications. If you found any of these active ingredients in your cabinet, write in the comments which ones you found and where you're watching from. This helps others see how common the issue is in different regions. I'll read the comments and respond where I can. I'll close with one final reminder. Medications save lives and treat serious disease. My aim is not to scare you away from treatments that are necessary. My aim is to give you the knowledge to be an informed partner in your care. Bones can be protected if we look for the problem early, test appropriately, and coordinate treatment. The title of this video is blunt because the reality is urgent. Some medicines can silently weaken bone, but action, auditing, asking, testing, and supporting works. It preserves mobility, independence, and quality of life. If you want the next video, I'll walk step by step through rebuilding bone safely. What supplements to consider when deficient, how and when bone-specific medications work, exercise prescriptions that actually help, and nutrition strategies that matter. Click the link in the description to watch that follow-up. Remember, do not stop any medication without talking to your prescriber. Instead, do this: audit your medicines, make the list, and bring the list and the exact questions I gave you to your clinician. That conversation can change the trajectory of your bones and your life. Thank you for watching. Share this with a family member who takes daily medication. Get that medicine cabinet list ready and take it to your next appointment. I'll see you in the next video, where we'll talk about how to rebuild bone strength with safe, clinically proven steps.